колеги, розпочинаємо наш вечір професійного розвитку у сфері ментального здоров'я. І цей проєкт реалізує Координаційний центр з психічного здоров'я Кабінету міністрів України в межах всеукраїнської програми ментального здоров'я ТИЯК, яка є ініціативою першої леді України Олени Зеленської. І знаєте, шановні, щоразу, коли бачу таку кількість зареєстрованих учасників, а сьогодні їх понад 2000, розуміємо, наскільки сильною є зараз потреба в підтримці, в знаннях і професійному діалозі. Саме тому такі наші зустрічі про професійний діалог і про доступ до фахівців світового рівня, до експертів світового рівня. Ми сьогодні обрали продовження теми, яка залишається непростою, але критично важливою, про сучасні підходи до лікування посттравматичного стресового розладу. Нагадаю, що у центрі нашої уваги саме доказові, науково обґрунтовані підходи до лікування посттравматичного стресового розладу, які підтверджені міжнародними дослідженнями та практикою роботи у складних та кризових умовах. Тому для нас було важливо, щоб цю розмову вів фахівець із глибоким практичним і дослідницьким досвідом. З нами сьогодні доктор Ізраїль Ліберзон, психіатр, завідувач кафедри психіатрії Техаського медичного коледжу, дослідник ПТСР і нейробіології травми, який роками працює з людьми, що пережили війну, полон, катастрофи. Вітаю вас, професор Ліберзон. І до розмови доєдналася також докторка Тетяна Нікельсон, професорка з досліджень кафедри психіатрії та поведінкових наук Техаського університету. Якщо потрібно, пані Тетяна долучиться до секції питання-відповіді. І нагадаю, що цей цикл, присвячений темі саме посттравматичного стресового розладу, ми з пані Тетяною придумали і тепер реалізовуємо разом. І я неймовірно вдячна команді фахівців з Техаського університету, які для нас ці знання роблять доступними. Давайте ж декілька слів щодо організаційних питань. Ми з вами працюємо 1,5 години. Година лекції і 30 хвилин на секцію питання-відповіді. Запитання можна залишати в чаті протягом лекції. І наприкінці я їх всі озвучу, і наші спікери дадуть на них відповіді. Нагадаю, що у нас ще з минулої зустрічі з доктором Мюллером залишилось 2 запитання від наших учасників, які він одразу переадресував до професора Ліберзона і пані Тетяни. Тож з них я почну якраз секцію питання-відповіді. І для наших учасників нагадаю, що ви можете до нас приєднатися за посиланням на Zoom або переглядати в прямому ефірі на Фейсбуці Координаційного центру з психічного здоров'я Кабінету міністрів України, під'єднавшись до трансляції. І, що головне, відеозапис сьогоднішньої зустрічі ви зможете переглянути так само на нашому Фейсбуці. Тож, дякую, що ви з нами, і передаю слово доктору Ізраїлю Ліберзону. Прошу вас, будь ласка, з вашою лекцією, пане професоре.
Thank you so much. Thank you very much. And I'm honored. It's a great pleasure. And I'm touched by the interest and of so many Ukrainian specialists. And a little bit nervous. I don't remember myself talking to 2,000 people, but there's always the first time for us all. So I hope I will be able to address some of the issues of interest, and specifically post-traumatic stress disorder. And before I go, I just wanted to check with the team people can hear me, people can see the slides, people can see me. Is everything technically working well? Yes, okay, good. I wanted to
Можемо
verify.
розпочинати. Вам натхнення, не нервуйтеся, все буде добре.
Good, good. Thank you. Okay, so what I wanted to start with is to simply try to, first of all, bring a couple of topics in the title. Everybody understands the importance of PTSD. I don't need to explain that to Ukrainian specialists. You're dealing with that as much as anybody else, even more. But the title has, in addition to PTSD and the treatment of it, two other topics: mechanisms and evidence-based approaches. Why those two? Mechanisms are critical to understand, in my mind, because we do not know the exact etiology of this disorder. It's not only for PTSD, where, as a matter of fact, we don't know etiology for any psychiatric disorder. But we do know the brain mechanisms involved. There is a lot of work done there. The brain mechanism involved cannot yet direct all of our treatments. But if we use evidence-based approaches, and evidence-based means approaches that there is a scientific and clinical evidence of effectiveness and efficacy. If we use those approaches and think about the mechanisms that are involved, we can try to address the individual patient's needs. The evidence-based approaches in general address the group of patients, because the evidence are never about a single person. Evidence is always based on the group approach, right? But that's not enough, because each patient is a little bit different. So to be able to adjust treatment based on first evidence, because if something is efficacious, you probably should do that, and not something that you decide to treat for whatever other reason. But then also think about the mechanisms, because not everything has been studied to provide evidence. Putting it all together in a single analysis of your case is critical to provide the best possible treatment to your particular patient. Let's go back to post-traumatic stress disorder and just remind you that post-traumatic stress disorder is a disorder that develops in people exposed to life-threatening situations. Life or body integrity threatening to them, or somebody very close to them, or somebody nearby them. It's not a disorder that develops in everybody. And that's very critical to understand. If you see the line before the last one, lifetime prevalence is 4.8% in population, at least in the US. The prevalence of trauma is actually much higher, even in the US, up to 80% from Naomi Breslow studies of the population are exposed to what we call qualifying traumas. The four pictures on the side actually demonstrate different types of traumas that could lead to that. Terror act, car accidents, natural disaster, war, personal attack, rape, all of those could lead to post-traumatic stress disorder. But important to recognize that it's not in all of the people exposed. So it suggests that PTSD, it's not a natural history of the exposure to trauma. And I would like to suggest that we think about that, at least I propose to think about that, in a sense of failure to recover. The majority of people exposed to trauma will recover. Actually, part of the people who even develop PTSD initially will recover, even if you don't treat them. But some of the people, and it depends on the trauma, will have protracted symptoms which undermine their physical functioning, social functioning, health altogether. And those people you need to treat. And today we'll be talking about treatment. I understand that Greg Mueller talked earlier last time about psychological treatment. He's a member of our team. And today we try to focus on other treatment and mechanism, mostly pharmacotherapy, but also mention a couple of other approaches to try to make it a little bit more comprehensive. Remember that we have 4 core symptom clusters, one intrusive and re-experiencing cluster, and this is mostly driven by memory mechanisms. It's reliving memories of trauma, recollection of trauma. And it says intrusive because it has to happen when person doesn't want it, as opposed to rumination or somebody who kind of lives in the past and wants to continue doing that. The idea here is that people try to push it out of their awareness and it still comes back. There's avoidance, it's a behavioral, and all the steps that people take in life in order not to get re-exposed to traumatic reminders, negative attentions, and negative cognitions, and about associated with trauma, because trauma changes beliefs in the world, emotional and cognitive, the concept about how people are safe, or how safe is the world, the concept about how they are capable of protecting themselves and predicting that their lives will be manageable, as well as alterations in the arousal systems and the physiological reactivity. For example, increased autonomic arousal, sleep difficulties, what we call startles, and so on. Obviously, all those symptoms, as I mentioned, has to have a duration and severity levels. Duration, it has to be at least for a month, because as a matter of fact, after the trauma, the majority of people who expose have some of those symptoms. But in the vast majority of those people exposed, they disappear. So only in those where symptoms stay for a long time, you probably want to start treating it. I say long time, from months and up. As a matter of fact, in most cases, you usually don't. But I've tried to treat people with acute stress syndrome with severe symptoms in the first month. You will find out that the majority of them will actually decline treatment because they think that that's a normal. Everybody feels normal if they have memory of something that happened to you just recently. They come back to treatment only when they think that things don't go away. And one important thing to mention is that in PTSD, the additional symptoms are critical, and the additional symptoms are usually symptoms of anxiety, symptoms of depression, and the comorbidities are more rule than exception. As a matter of fact, if you look on PTSD patients, 80% of them come with some comorbid conditions. Now about the mechanism. The mechanisms are complicated. And yes, we do understand that at least in this psychiatric disorder, the experience plays a central role. But how? How's the trauma that happened before, let's say 6 months ago or 3 months ago, leads to the symptoms today, and why in some people and not in others. This is a picture, I call it long road to understanding cellular and molecular processes. When the PTSD diagnosis was first established, and this is 1980, as you can see, what we knew was what's going on in the brain in PTSD was a black box. Basically, we had no idea. Behind this black box, and that's what people relied on, was theoretical postulates of analytical psychiatry, which meant, um, you know, you probably, some of you who can guess based on the cigar in the hand that was Sigmund Freud's picture there. At that time, psychodynamic thought prevailed, and the hypothesis was, well, it has something to do with a childhood. Since then, we made quite a bit of a progress based on evidence. And initially, before we had real brain imaging tools or ways to look into the brain, we looked on the periphery, and the periphery was blood, urine, even spinal cord, and we kind of thought about it. And that was a period, maybe in 90s, what I would call that a soup period, when we thought about too much of hormones, too little of neurotransmitters, and that's how we hypothesize mental illness processes. Too much norepinephrine, too much cortisol, too little serotonin. Too little serotonin, you have a depression. You have too much norepinephrine, you have a maybe PTSD and so on, or anxiety. That's a kind of a soup period. As things developed, and it's interesting to remember that in the 1990s, it's not only that we didn't have the imaging tools, but we also had no animal models. And there was a still strong dynamic misconception that animals, you cannot study emotions by using animals. And only somewhere in 90s to 2000, the animal model became a central part of neuroscience. It's called affective neuroscience. Joe Ledoux and others have developed some of the models of fear and demonstrated that amygdala specifically, but also other regions, but nucleus stria terminalis and others, locus coeruleus, are very important for the expression of fear, and showed us that we can study fear-related behavior in animals. And that brought another place in this saga of understanding mechanism of PTSD, and I call it amygdala, the seat of the soul hypothesis. It's back to the Descartes, if those of you who are interested in history, who spoke about Descartes, who spoke about pineal gland, the seat of the soul. In 90s and then 2000s, the amygdala became the seat of the soul, and everything what was wrong with the brain was related to amygdala. And only with really full development of functional MRI and other very complex neuroimaging techniques and the psychological sciences that utilize the technique, we could move beyond the simplistic models that we can model an animal and place it in the brain of individuals, people. Try to recognize that while some of the areas, the basic science are correctly pointed out, are involved or potentially play a role in the disorder, that's not a seat of the soul. The circuits, the neural circuits involved are the combination of functions. They are the ones who govern behavioral responses rather than a single area, and understanding the function of those circuits that connect multiple brain regions. And based on understanding of this, understanding the potential development of particular symptoms or source of this particular symptoms really allows us to try and to treat psychiatric disorders in general and PTSD in particular in much more thoughtful way. And we also start realizing on a molecular level that multiple steps and multiple level leads to symptom development. It involves genetic predispositions. No one gene predicts vulnerability to psychiatric disorder, but set of genes that support set of systems. It could be HPA or stress axis genes related genes. It could be norepinephrine related genes which support the sleep and REM sleep specifically. It could be other mechanisms involved. That's all lead to neural circuit changes that in turn lead to specific deficit in patients' function that leads to PTSD symptoms. And if we think in those terms and that start making sense to us, we can put together with the most reasonable evidence-based care because we can study the evidence-based treatments based on the way we understand the neural circuits. Without going in too much into that, just to mention, we have at least four sets of large mechanisms and circuit that might be involved in PTSD symptoms. Indeed, amygdala and BNST and the circuits that regulate amygdala, like medial and lateral PFC, that responsible for expression and learning of fear, but also of safety, are critical. But it's not only that. We do understand that attention modulating circuits, such as ACC and insula, are also critical. This is what we call in the resting state salience network, because we know that in PTSD, attention toward signals that potentially are threatening are enhanced. But at the same time, also other circuits, for example, and this is our group was focused a lot on hippocampal, thalamic, prefrontal circuits are critical because they are the ones that identify the context. Not only the cue, the signal, is the context. You can see a lion and you should be afraid of it. On the other hand, if you see a lion in the zoo, you should not be afraid of it. And maybe what we are thinking that contextual processing, the circuits which allows you to immediately automatically identify the context. Are you in the zoo or not? Should tell you and govern your fear responses. And that might be a major problem in PTSD. So when we think in those circuits, if we understand what could contribute to particular symptoms, then we can try to use the therapeutic approaches that particularly address these specific circuits. And I will, when I start immediately talking about treatment, I will hopefully use some of those examples to treatment, how we think about treatment, how it relates to particular circuits. At this point, I'm transitioning to circuits. I understand, Bohuslava, that all the questions are left to the end, right? Am I correct? Yeah. So it's a little bit different to what I'm used to because I'm used to stopping because there are different themes and people can ask questions. But I guess I apologize. This is not the model here. So please keep your questions, write them down, and we can address them later. Now, what about the evidence-based treatments? There is a difference between the evidence-based and guidelines. guidelines are published by different organizations, often based on evidence base, but often based on interpretation of the evidence. And I will show you where those things come into play. But if you can look carefully, you see that there is many different guidelines. American Psychiatric Association guidelines, American Psychological Association, International Society for Traumatic Stress, Department of Veteran Affairs, and so on. Everybody created their own set of guidelines. By weighing what type of evidence available and what type of evidence is more impressive for them. But as a matter of fact, as you can see, not all of them are the same. So there is a need for each one of you to understand what is the evidence that they believe are sufficient that supports. There are some things that are very common. If you look on all the evidence, there is a CBT. CBT could be different types. Greg was describing to you, Dr. Mueller was describing to you in the last meeting, PE mostly, but also, I think, CPT, because that's have the most of the type of the evidence. On the other hand, there is other CBT that actually not very efficacious, and some guidelines still recommend that. I will give you an example. EMDR. EMDR is a great evidence-supported treatment, probably as effective as exposure. However, EMDR was not created by neuroscientists, in spite of the names. And actually, eye movement, specific relation of eye movement to REM, has nothing to do with the efficacy of EMDR. And that was demonstrated by Pittman and other study when they changed the movement from the lateral into horizontal movement and still had exactly the same effect of EMDR. So most likely EMDR effects is through the normal exposure plus attentional modulation. So is there evidence? Yeah, the evidence says you can use EMDR. The question is, do you need eye movement? Do you need all the things around it? The story is probably different. The same is true for CBT. There are many different CBTs and different approaches. There are also different evidence for SSRIs. For example, yeah, their SSRIs are effective. We know that paroxetine and sertraline have a strong support, and I'll talk to you about it in a minute. But for example, fluoxetine has much less supportive evidence, but it's listed in many guidelines because people who created the guidelines believe that they are from the similar group. They are from the similar group, but the evidence is a little bit different. And the evidence might be not only because they belong to the same group, but because different medication have different pharmacodynamics, pharmacokinetics, side effect profile, and those things might make some SSRIs more effective, some less, some more appropriate to this patient, and some more appropriate to another patient. So what is the current options for treatment of PTSD? The goal is reduction of symptoms and return the patient to the active life. Yeah, we would like to cure them, but losing diagnosis is not the criteria for efficacy. On the other hand, not meeting any more criteria for PTSD can be a goal. It's not criteria for efficacy, but it's a very good goal. And some of the studies, and I'll give you one example of our study, that demonstrate that at least in 15 to 20% of the people, you might be able to get to the point that PTSD people do not meet diagnosis at all, what we call recover. Psychotherapy, clearly prolonged exposure and cognitive processing therapy are the most well-established and supported treatment options. But they're not alone. Written exposure therapy, which is basically prolonged exposure modification, also have some support now, and we see that very much in the same line as prolonged exposure. Of course, difference is time, what is required, how people are willing to express themselves in writing, and so on. EMDR, as I mentioned, EMDR is, it looks, whenever it was studied, looks efficacious, at least as other prolonged exposures, not more, but, and probably with no connection to the lateral arm movement, but maybe with a connection to the way that attention is diverted from exposure at the same time that exposure is going on. I'm sorry, I think I jumped forward. Now, that's not the only treatment. There are plenty of other treatments, and some of them I'll be talking more about it. For example, what about repetitive transcranial magnetic stimulation? Very interesting, RTMS. We know that it has a place for depression. Can we treat PTSD with that? Is there evidence? There is some evidence, and there is some evidence that it might be not as effective. Let's talk about it a little bit. What about psychedelics? I actually would not want to talk about psychedelics, but I knew that that was some of the questions that people had. So I kind of borrowed slides about psychedelics from a friend of mine, and he's a professor and chair of the department in UT Austin, in Texas, University of Texas in Austin, Dr. Nemiroff, and I brought them here. You will see, and I'll talk a little bit about psychedelics because I understand there is a lot of interest about it. What about the other things? What about ketamine? What about second generation antipsychotics like brexpiprazole? So there could be a role for those medications. There is some initial evidence, not enough to say that they are indicated or these are evidence-based therapies. But they're also completely novel thing. For example, low intensity ultrasound that my colleagues and I are studying, the transcranial direct stimulation, stellate ganglion block, and so on. There are many different things that are going on. We cannot talk about in one lecture about all of that, but at least we can mention that, and I can try to address questions about some of it if I can at the end. But let's go back to the specific, and we'll have to talk about specific what we have today. What are we targeting? We're targeting limbic brain. Limbic systems, hippocampus, amygdala, raphe which is not limbic, but serotoninergic systems, and so on, with cortical areas. We're changing neurotransmitter. Specifically, most of the evidence suggests that serotoninergic pathways need to be changed, but not only. We have some noradrenergic pathways that might be involved. Clearly, ketamine working in the glutamatergic pathways, some questions about GABA, and maybe even dopamine. We are targeting specific symptoms like nightmares, flashbacks, panic attacks, as well as numbing and social withdrawal. But we're also targeting depression and anhedonia because some of the depression could be negative symptoms of PTSD. Some of the depression could be secondary depression. And then could be also hypervigilance and so on. So, and sometimes while we're trying to hit all of those symptoms with some of the specific evidence-based supported medication, then we need to add and modify that, adding additional agent with our thinking about neurotransmitter pathways. What about psychotherapy and pharmacotherapy? Well, psychotherapy in my mind, is no different from psychotherapy. We know that the learning, it's a brain-based mechanisms. And every psychotherapist will tell you, and definitely CBT therapists will tell you, that it's all about learning. PE is all about learning. Not learning like in school, but learning by experience. And learning by experience and changing the same brain circuit. As a matter of fact, we know that. That's how fear learning occurs, right? In amygdala. But not only learning, but also fear extinction or learning safety also occurs in the circuits related to amygdala and prefrontal cortex, and actually is modified by hippocampus, because context is critically important in balance or in learning safety. Should one combine those? Naturally, some would say yes. I'll give you an example of the paper that we have published in 2019. We thought if the PTSD is treated well by medication and treated well by psychotherapy, how about we put them both together? This is the result of the study. As a matter of fact, it's the only study so far that contrasted medication to psychotherapy, to combination of medication and psychotherapy directly. It's a random assignment, multi-center study, state-of-the-art treatment, both psychotherapy and medication. If you look on the previous slides that I was talking to you about, evidence-based, people based on evidence-based were arguing that psychotherapy is more efficacious than medication. I think it was a reasonable argument at that point to make, because if they did it based on effect size, they did an effect size and argued that effect size of PE is higher, above 1 and so on, and effect size of medication is lower. So all the guidelines, when they compared those, argued that you should start with PE and not with medication, but then move to medication. But this is the first study that actually, in a double-blind, placebo-controlled, randomized assignment, compared PE and the medication. As a matter of fact, it compared it by also giving placebo. PE plus placebo, PE plus medication, and medication plus placebo PE. They were given psychotherapy, but not exposure. And as you can see, there is no difference between the effect. The effect, all three of those were effective. And all three of them were pretty much similarly effective. So the hypothesis that one can say, oh, in my study, I studied PE or CPT, and in a different study, they studied EMDR, or in a different study, they studied medication. And this is better because this was a bigger effect size. That doesn't hold. You really cannot compare efficacy of treatment without a random assignment. And in this particular random assignment, in the largest study that we have done that in pretty big groups, as you can see, about 70 people in each group. The evidence is clear. Now, there will be some arguments, and my own colleagues will argue that the issue of adding placebo pill might be changing PE in general. I can buy all the arguments and so on. But arguments is one thing and evidence is another. Arguments and interpretations of the evidence. You see the evidence. PE is effective, medication is effective. What is shocking to me and to others, when you add medication and PE together, you don't get necessarily benefits. I will leave that for people's interpretation, saying everybody can think about it. Maybe because it is done in a randomized fashion. Maybe if we add the exposure therapies or medication in a more thoughtful way, not a randomized way, there will be efficacy differential. That's what you'll have to decide when you see your patient. This is the evidence for unique SSRIs. You can see 4 studies for paroxetine with some significant difference. That's pretty good. Sertraline, 6 studies, 3 studies with and 3 studies without difference. Now, those studies had a different explanation and so on. Fluoxetine, that's the problem. 2 studies with significant difference, 3 studies without. Citalopram, relatively small amount of studies so far on. The one good one with randomization and double control, and it's looks significant. So yes, there is evidence, but realize that we have, in order to get into the indication in the United States, the FDA requires at least 2 positive studies where the medication separates from placebo or treatment is usual, whatever the control condition is. It has to be double-blind, placebo-controlled, randomized, sufficiently powered. So 15 or 20 patients is not powered. Usually 50 patients are not powered. So in order to get an indication, you really need hundreds of patients in your study. The question becomes, why don't all other medications get indication? Well, it doesn't mean that they're not efficacious. It means when there are 2 of them already received FDA approval, we can prescribe others. It's can be prescribed outside of they are already have indication for depression. We can prescribe it for PTSD. It's not a problem in United States. It's based on the clinical decision of the physician. So the difference between paroxetine and citalopram is not that paroxetine is better than citalopram. It's simply that paroxetine was earlier and sertraline was earlier, was the first one, and they already get indication. And citalopram was not looking anymore for indication because it doesn't make any sense for them to invest so much money. They can be prescribed, people can prescribe citalopram already. So this is example of what is the studies, randomized double-blind placebo-controlled studies. So if you can see here, you need at least large scale study like this one, and maybe another one with that, at least like this one, that to demonstrate that your medication can get FDA approval. This is a sertraline. Large-scale studies got approval, but there are some studies that demonstrate it doesn't work. If you look, this was done by Matt Friedman and Kat and Brady. The problem with those studies were, for example, that these were done in Department of Veteran Affairs. And the patients in Veteran Affairs were different than the patient in these 2 studies. And the result of those arguments was that maybe veterans do not respond so well to sertraline. Well, that's not what we saw. I think the main issue there was that the chronicity, it's not what the fact that they were veterans, but the fact that they were having, this is a study published in 2007, and some of the patients there from Vietnam War or early Iraq War with a much, much longer chronicity of the illness. So serotonin reuptake inhibitors are in general, as I demonstrated, efficacious. They're first line of treatment. But again, you need to think about additional components, and I'll talk about it later. Another important component is adrenergic component, and I'll talk about it in a minute. we have some evidence, and it makes all the sense. Adrenergic agents like prazosin, which is originally antihypertensive medication, decreases the signal, adrenergic signal, by blocking alpha 1 receptors. Actually, by activating that, decreases the neurotransmitter. By downregulating it, decreases the signal. It's not blocking them. I apologize. It made sense to study that, and Murray Ruskin indeed studied that. Wonderful idea. And we learned something from those studies. And this is the example. Murray and Elaine Peskin, together with Murray Ruskin from Seattle, studied that first time in 2007 and published a nice paper of effects of prazosin on PTSD symptoms, R34, and it's 34. They did another trial and demonstrated efficacy with 67 people. And then they decided to do the multi-center study. And they did it with 152 people and showed the importance of large numbers. Because with the smaller numbers, you always can run into the chance. And that was the example of that. It did not work across the board. The prazosin did not separate from placebo. Now, there was another very important thing that came out of that. It was very useful because Murray and Elaine, who ran the study, they noticed the specific subset of symptoms went down. And subset of symptoms that went down specifically had to do with sleep. That pointed toward particular mechanisms, and that allows us to think differently about when we try to treat nightmares. So probably there is a good signal that noradrenergic agents might be effective specifically for nightmares. And if there is a questions, I will try to answer them later. Among the medication, we're also using medication, what we call anti-epileptic drugs, such as topiramate, and there is some suggestions, but ends are small. So what does it mean? It means it will never go to indication, and it means that it probably will not be used as the first line of drugs for PTSD. On the other hand, will we use sometimes topiramate? Yes, we will use that because emotional ability as an additional symptom treatment, in addition to SSRIs, needs to be sometimes managed with anti-epileptic drugs. And in those cases, we add either topiramate or other anti-epileptic component. The same thing goes for olanzapine. There is some suggestion, or quetiapine, or brexpiprazole, as I was talking about. There are some small studies suggested it might be useful agents. On the other hand, are they the agents that I would start with treating PTSD patient? Probably not. But if the PTSD patient, for example, has a strong dissociative phenomena, and this is specific more to the what I would call complex PTSD, or again, emotional ability that cannot be controlled with other way. Those cases, adding antipsychotics might be important. What about GABAergic agent? Most of the people know that benzodiazepines are not the one that we would like to treat PTSD with. Not only because there is a specific issue of dependence or misuse, but if you look historically, people studied benzodiazepines from looking on PTSD core symptoms. They are small numbers, but they demonstrated that benzodiazepines themselves really don't work on the core PTSD symptoms. They calm people down as long, and then usually there is escalation and so on. But it's not particularly effective with their core symptoms. There are more, there are more evidence of efficacy of, of pregabalin, and so on. Tiagabin, not so much, but these can be used as well using randomized double-blind placebo-controlled studies. Some support. Again, you might want to decide if you know how to use those agents, whether they can be added to your regimen for each particular individual, depends on their symptom profile. Glutamatergic agent, dicycloserine, ketamine, and memantine. So dicycloserine, 4 studies with significant differences, 1 study without significant differences. All of the studies that have been done, mainly done with augmentation, dicycloserine augmenting extinction. There is some signal, but on a large scale, it's have not been shown to be efficacious in adding to the PEO exposure therapy. Let me give you an example on what's going on with ketamine. The ketamine, this was a comparison of ketamine and midazolam, and they did separate. They both were similarly effective in decreasing the intrusive symptoms mainly, but also other symptoms. And why is it important to go with midazolam, talk about using midazolam? Simply because it is a, you can imagine that people who take or get infusion of ketamine, it's almost impossible to keep that blinded. There's no, if you compare to placebo, they immediately know what's the difference. I'll have the slide about placebo later on. But if you look on ketamine double-blind placebo-controlled studies, and that's one of those was, this is the Federer studies before that. If you look, the ends are relatively small. And then when you do larger study of the ketamine, and the evidence there demonstrates that in double-blind placebo larger control studies, ketamine did not separate. This is in veterans, but it's not in chronic veterans only. So that raises the question still, how's the ketamine, is ketamine really efficacious? In our hands, for example, this is a study that one of my mentees and I've done, load those ketamine, this is ketamine and for PTSD symptoms and chronic pain, it didn't separate from strong analgesic medication. So basically, both of them had significant effect on both PTSD symptoms and pain symptoms. So why RCT, randomized controlled trial data, is not enough? I mentioned individual differences, but individual differences are not only in symptom profile, but also in sensitivity to medications. And those might be the main problem. And again, the comorbidity are the rule. And RCT, randomized controlled trial, usually do not address the issues of comorbidity. Again, RCT, randomized control trial, also look on PTSD symptomatology in general, but not in a particular subset of symptoms. For example, that's the story with the prazosin. In general, prazosin was not effective, but it looks like it might be specifically effective for PTSD nightmares. And now we try to understand the mechanism, and there are some good ideas because of that. So there might be not a single best medicine for everything, but we should probably start with medication which is best supported, and then see what are the other treatments that needed to be added to create a best or the most efficacious regimen for your particular patients. Observation, what we call clinical pearls, are valuable. It's very important to understand that it all starts with observation, and then it has to be studied in a controlled fashion. But you cannot close your eyes on observation. You just need to demonstrate and really test it and see is it subjective experience or there is some commonalities behind that. Furthermore, clinical context matters. For example, the way we do it, we often improve sleep. But we also think about, how we improve nightmares, prazosin, doxazosin, mirtazapine, trazodone. We can do all of those components that we can add to SSRIs. We can also sometimes think about TCAs or tricyclic antidepressant because, like amitriptyline, because of their major effects on sleep. They also have a lot of other side effects. Therefore, one has to think about it very carefully. Other contextual factors, it's very important. Somebody who is at the same time is under threat, you will not be able to make them less vigilant. We know that. We don't start PE therapy or that with somebody, I'll give you an example, who is continuously under threat, whether it's a woman who is in the abusive relationship and stays in the family, was traumatized and she is not ready to leave, or it's a soldier who goes back to the front line who was traumatized, and you cannot expect that the hypervigilance will decrease. It's important to understand the family history because it's important to understand how early trauma occurred, access to psychotherapy, quality, and so on. What are the take-home points? Learn how to sequence med, integrate them, foster synergies. Good meds and good therapy are both critical to optimal treatment. Med can enhance capacity to use psychotherapy. So you can start with meds, move to therapy. You can do other ways. Either way is okay. Sometimes people are not interested in meds. They want, in the United States, they often say, I don't want any pharmacology. I want to try psychotherapy, but psychotherapy might have a big dropout rates, 30 to 40% in PE. It's very hard for people to maintain that. So people try that and then step back and use pharmacotherapy. Using and choosing SSRIs, I mentioned data versus experience. One has to think about your own experience. We use escitalopram, but citalopram, more the paroxetine because of side effect profile and ease of translation. But it doesn't matter. You can use paroxetine, you can use sertraline, especially here, for example. What about sexual function side effects? Sertraline in our hands might have lower, a little bit lower. And then you can also do it morning versus night for sertraline and so on. Fluoxetine has longer half-life. It could be bad, it could be good. You can think about it, whether that works for you. Remember that fluoxetine has quite few studies that basically showed negative, maybe because of the long side effects, long presence, and therefore maintenance of side effects. Quick titration versus the range, it's also an important component to think about. SSRIs versus SNRIs. We have using SNRIs, noradrenergic reuptake like venlafaxine. I use that specifically when there is also symptoms of depression. As I say, refractory depression, I might add that, I might switch to venlafaxine from original SSRI. Targeting anger and irritability, I mentioned that before. Sleep is critical component to manage those things. Complex versus simple simple PTSD, and consider adding mood stabilizer, as I mentioned, or even second generation antipsychotic. I think we're gonna skip that one because I want to talk 7 minutes about the psychedelic. Psychedelic really does not deserve the place to be discussed at this point as evidence-based pharmacotherapy for PTSD. However, as I said, there is a lot of interest. I understand our Ukrainian colleagues are very interested in that. And there are other reasons that they have been used in depression and probably would in other areas in psychiatric illness. And naturally, people will be talking about doing that for PTSD. Psychedelics are done with so-called psychotherapy. I have a hard time to understand the concept that people use there, such as opening and or being one with everything. I kind of thinking in terms of pharmacology. I'm intentionally making a little bit anecdotic this kind of description, but one who have to understand that psychedelic comes from the concept of profound, expanded, and experience or intensity, very subjective one. We do know that objectively the person is have conscious awareness changes and sensory perception changes. But what does it all mean from our perspective? Well, the common psychedelics are psilocybin, some mescaline, and obviously DMT. And some of the synthetics are LSD, and here I included MDMA. In my mind, LSD and MDMA, well, LSD, yes, but MDMA don't belong really in the psychedelics. The psychedelics, when it's not a new thing, there was a started in early 70s, even before that in 60s, and it was Timothy Leary and others. There was some evidence of resurgence in 90s, response to DMT in healthy control, then psilocybins in healthy volunteers. 2011, first actual randomized controlled trial of MDMA, assisted psychotherapy, and then psilocybin for anxiety in end-stage cancer patients. And finally, we now have actually psilocybin for treatment-resistant depression and so on, and we have some of the large-scale studies. It's important to know is that people throw everything together. It's not the same. I think some of the blame is on the people who work in the field of psychedelics because they don't really care about pharmacology or mechanisms. One of the things that separates some, for example, people try to start separating psychedelics versus empathogens. Empathogens are entheogens. Entheogens. So the example of empathogens is MDMA and some of the others. And the psycho that basically suggests that people feel empathic and connected to others. Doesn't matter where it comes, the definition, but basically from the concept of being empathic. Versus psychedelic has a different, somewhat different experience, changes in sensory and in basically in consciousness and in the sensory domain. So that would be the example: visual, auditory perceptions changes, relation of self to body, and that's exactly introspective kind of sensory consciousness thing. Spiritual, it's a feeling of oneness. I don't know what does that mean, but that's what people report. Unity with everything, um, transcendence, and so on. It's difficult for me to talk about that because I don't find that in my vocabulary of scientific terminology. It's difficult to me to say what is it other than subjective report. People report euphoria, good feeling on psychedelics, reduced ability to concentrate in cognitive domain or engage in linear thought. They think that they have enhanced creativity, and some people would argue that LSD increased their creativity. Some artists, it's clearly not the something that you need or helps you to address everyday tasks, but if their creativity is your issue, you might do that. I don't necessarily see how that will be effective for treating psychiatric illness like PTSD. And then there is a physiological and social evidence of this kind of psychedelic effects. The pharmacology of classic psychedelics, and we talk about psilocybin, LSD, DMT, and mescaline is one. They affect primary via binding to 5-HT2A receptors. Blocking 2A receptors will stop effects of psychedelics. An intensity of subjective effect of psychedelics correlates with receptor binding. But it also binds to other receptors, such as 5-HT2B, 5-HT2C, and so on. It also binds to histaminic receptor H1, alpha adrenergic receptors, and so on. That makes some suggest at least that they have a similar, how would I describe that, psychological effects, the subjective effects. However, pharmacology MDMA is very different. It's amphetamine or amphetamine derivative. It was used again, as I mentioned, in the 60s and 70s. It's kind of empathogen, but it's not primary serotonergic agent, and it doesn't typically produce hallucinations or mystical experience the way that psychedelics do. So in my mind, one should not be mixing up MDMA and psychedelics. And clearly, one should not be mixing up psychedelics, serotonergic agent, with ketamine. And people usually do that. Actually, as a matter of fact, the ketamine is glutamatergic allostatic modulator and was defined as dissociative agent. As a matter of fact, 1964 paper that was called by a friend of mine who passed away, Edward Domino, called ketamine discovery 1964 dissociative anesthetic. Clearly, cannabis and marijuana THC component with mainly THC, but also other cannabinoids. They working in endocannabinoid agonists. So really in other area of the brain too, and in other systems, and endocannabinoids have to do with some of the learning mechanisms, and that's where people were thinking of using them. Very different pharmacology and target neurocircuits, and should not be mixed up again with the concept of psychedelics. Um, there are many troubles with trying to get people on psychedelic research. That's one of the reasons why we actually, I'll summarize that in a very simple way. There is no psychedelic evidence of psychedelic efficacy in PTSD. Right now, I've seen nothing that shows PTSD specific effect. Um, these are side effects: transient elevation blood pressure, nausea, vomiting, physical discomfort, headache. The percentage is pretty high. The problem with that is a blinding. You cannot blind somebody to demonstrate efficacy with psychedelics. Plus the sociocultural homogeneity. Look, if you look on all the studies in the United States, in almost entirely white, Caucasian, and highly educated people. This is an example that I was talking to you about placebo. Look at two groups here, one group therapy and another group therapy, both using psychedelic versus placebo. And this line says, so I guess we are in the placebo group, obviously, because it's impossible to blind effectively psychedelic. And that creates a major issue because expectation is a major problem. There were some areas that psychedelics have been demonstrated as potentially effective. Um, Specifically, this study was only N of 12, but this is the people with terminal illness. It's very important to help people with terminal illness. I don't want to say it's not. To decreasing the anxiety, and probably very little other things helpful. On the other hand, can we move out of that into expand it to other disorders? I don't think so. I think that um, in this particular case, there was a compassionate reason to use this particular study and use this particular psychedelics. So if you can see, placebo in this case did nothing, and psilocybin did a little bit better. There is some suggestions right now in a large RCT, randomized controlled trial of psilocybin. Um, there is some suggestion that there will be controlled compass study pathways. This is compass pathways is the producer of artificial artificial psychedelics, and specifically for treatment-resistant depression. And that's an interesting findings because they compared different levels. And if you see here in the red line that this is a 1 milligram is probably means nothing, it's placebo. And 10 milligram that doesn't separate, but 25 milligram does separate. Treatment-resistant depression, 25 milligram over time. This is a two-dose administration study and effects in 9 weeks. Very interesting. So I think that people will continue working on treatment-resistant depression and see whether psychedelics are working there. I was talking about difficulties to get a signal. Please look on this slide. This says suicide of a patient shortly after psilocybin. I can give you many, many other examples where there's a significant major side effects. psychosis, suicidality, and so on. These are not benign medication to take, especially if you do not have a good indication. I have a problem with this concept. I don't have a problem of treating people compassionately, but primum non nocere. First, do not harm. This is not a simple concept here. I do not want to be in this position of those authors who deal with potential suicide on medication that we have basically no strong evidence of efficacy. We also have a problem with esketamine. People try to move from ketamine and esketamine, and there is a side effects. And esketamine is actually addictive. So when one tries to do things which don't have an evidence base and they're cutting edge, so-called, I personally think that their burden of evidence is much higher. So one has to be very careful and make sure that they know what they're doing and make sure that they have a good internal justification in trying to use drugs that have a strong addictive potential or some potential for causing very long damage or even bringing people to suicide. This is MDMA. There was an attempt to get MDMA that, again, it was used as a compassion drug for try to do fast track for PTSD with particular psychotherapy combined. The FDA panel rejected the efficacy of MDMA PTSD. It will not be used for PTSD. Many different reasons. And I'm just here quoting something. Member of the independent scientific advisory voted 9-2 that human trials MDA did not prove efficacy. The other issues with MDMA was not only that it didn't prove efficacy, but the problem was also that whatever so-called therapy that was combined with MDMA doesn't sound like could be explained in any scientific way or even standardized. So if MDMA people want to show more, I think it's a legitimate question. They have to develop better definition of what the psychotherapy is all about, how to do it, how to control for that, and then to do larger studies to demonstrate effect. So I hope I gave you, I know I took longer time. I hope I gave you a lot of information to think about. And I would like to thank you all for attention and open for discussion.
Дякую, професоре. Так, ви трішечки затрималися, але втім ви торкнулися теми. Я знаю, що ви не дуже хотіли про це говорити, про застосування психоделіків. Втім, ця тема є досить маніпулятивною і певною мірою спекулятивною в Україні, враховуючи, що багато фахівців з усього світу намагаються сюди приїхати зі своїми рецептами рятування від наслідків такої важкої війни і наслідків травмуючих подій. Тому дякую, що ви на цьому науково і обґрунтовано зупинилися. Для наших учасників я нагадаю, що ви матимете можливість переглянути цю лекцію в записі. Вона буде доступна на Фейсбук-сторінці Координаційного центру з психічного здоров'я Кабінету міністрів України. Протягом цієї лекції до нас доєдналося майже 600 людей через платформу Zoom і в прямій трансляції на Фейсбуці. Ми маємо низку запитань, і я, власне, до них зараз перейду. Пані Оксана Гук запитує, чи лікування антидепресантами є дієвим при ПТСР.
So yes, it could be. There's a good evidence that antidepressants, because they have the same mechanism of action like SSRIs, not all of them. The one that, for example, diazepam is probably the only one who doesn't have enough sufficient SSRI action at all, so I would not go for that one. But if you're talking about old style antidepressants, amitriptyline, or imipramine, yes, those probably are effective. They probably have more side effects and maybe a little bit less effective than SSRIs. But if you're using them as because if people have more, let's say, problem falling asleep and you're using amitriptyline because it helps them asleep, I would not add SSRI to that. So they are not indicated, but they're not indicated from, as I explained, for different reasons. Some of them are commercials, they have not been studied in this scale, but conceptually, the mechanisms make sense. So they might be effective for your particular patient, and it might be not. Please think again about the dosage and the side effects. These are not the medication that I would start with, but I would definitely consider them as something in your arsenal.
Дякую. Хотіла ще зазначити, пане професоре, перш ніж поставлю наступне питання від наших учасників, про те, що для вас, шановні колеги, і учасники, хто нас зараз дивиться, про те, що доктор Ізраїль Ліберзон зі своєю командою науковців, фахівців в Україні реалізує проєкт вже майже 1,5 роки, якщо я не помиляюсь, з навчання фахівців українських та молодих українських науковців. І ми за це вам дуже вдячні. Я знаю, що ви декілька разів були в Україні, ви в українському контексті повністю. І я пригадую, що наше перше з вами знайомство було про те, що ви сказали, що ви відповідаєте за кожне своє слово, і ви все знаєте про лікування ПТСР. Принаймні те, що відомо науці на сьогодні. І наступне запитання. Від пані Тетяни. На думку професора, чи підходить терапія DBR для лікування ПТСР? Deep Brain Reorienting.
Okay, so let me thank you, Pani Oksana, for that. I don't know. Maybe I didn't express myself well enough. Nobody knows everything about treatment of PTSD, and nor do I. And I don't claim to know everything. I just claim to know the scientific evidence that is there, because that's what I do. And within the same vein, a lot of people propose multiple treatments. DBR, I did not see any evidence that demonstrated PTSD efficacy directly, and I'm talking about double-blind randomized controlled trial. And therefore, I will not be recommending anything that has no evidence. You can ask me, well, but Dr. Lieberman, didn't you just answer about antidepressants? Yes, I did. Not because I did, because I do understand that the mechanism is the same as something that have been proven efficacious. And I say that's not the first thing that I start. I always start with something that has been proven and then add or change or modify. So I would approach the same way um, psychotherapy or body-based kind of treatments.
Дякую. Від пані Світлани Товкач маємо таке запитання: чи може EMDR-терапія використовуватися для корекції ПТСР при наявності у пацієнта супутньої мінно-вибухової черепно-мозкової травми? Це дуже поширені випадки серед ветеранів, військових, саме ось такого комбінованого ПТСР.
Yeah. So that's a very good question. Thank you. Others, I didn't say very good questions before that simply because I'm not polite enough. I apologize. This is a good question, and otherwise also good questions. But this is a good question because it also deals with a large number of things, and I forgot to mention that. Um, it's a very common in concussion, contusion, all of the brain trauma cases that also there is a PTSD. It's important to know that the symptoms are often confusing. And I like to make sure that the diagnosis is well established. And that's difficult because in concussion contusions, there are often deficits in the memory. And if there is a deficit in the memory, how do we know that they have PTSD? What comes back? Are there really intrusive symptoms and so on? If there is a clear intrusive symptoms that can be demonstrated, and the people contusion and concussion is not severe enough to cause them severe significant learning deficits. Now if you have you understand if the trauma is major, learning is problematic, so psychotherapy becomes difficult regardless of what type of psychotherapy. But if their learning capacity is preserved and the PTSD is established, so you can identify the intrusive memories that you can do EMDR to, there's no problem of doing EMDR the same way that it's no problem to do WET or PE.
Дякую. І в продовження цієї теми запитання таке: наскільки ефективним є використання МДР для лікування ПТСР у ветеранів, зважаючи на те, що згідно з настановами НАЙС британськими, цей метод не рекомендовано як першу лінію втручання для цієї групи?
Yeah. Once again, I think that it really depends. It depends um, on the specific population and how much they are following the protocols and so on. I do not believe that veterans are particularly different. Remember, I brought it up for American veterans that, for example, sertraline was not an effective in particular study where majority of people, veterans. I don't believe that the issue was because they're veterans. I believe that that was the issue of chronicity. There are also other difference. For example, other difference has to do with sex. We know that veterans, the majority of them are male. A lot of early EMDR work was done in females. Could be the difference are in is sex dependent. There's not enough data for me to say that, but I believe that could be more important differential than the fact that person is a veteran. I'm not myself recommending EMDR, but I also to be honest, I don't feel that I can say that no, it should not be used the way that they feel in a British context. Each context might be a little bit different. Therefore, I would say EMDR is a legitimate exposure therapy. I would not be doing EMDR, I would doing exposure, but that's or written exposure and so on, but not because of the veterans. But right now, if you're putting together, written exposure is also short, similar to EMDR, relatively compared to PE, and people might be willing to do that. So if you're going to the exposure direction, I might want to try that one first, but I don't want to say that EMDR will not be working in Ukrainian veterans.
Дякую. Пане професоре, ми перебираємо вже час. Якщо ви маєте ще 10 хвилин, давайте, скільки встигнемо, одне-два запитання я поставлю, і все-таки тоді будемо фіналізувати. І я додам для наших учасників про те, що ми поділимося презентацією з тими, хто реєструвався на перегляд цього вебінару. Є окреме питання про особливості лікування ПТСР у дітей, але мені здається, ми маємо винести його, можливо, в окрему секцію, щоб зараз цьому приділити більше, щоб приділити потім цьому більшої уваги. А зараз щодо медикаментозної фармакотерапії. Кілька разів чула від людей з ПТСР, це пані Катерина ставить питання, що їм виписували препарати з фенібутом. Чи могли би ви прокоментувати використання фенібуту як при ПТСР, так і взагалі?
I'm sorry, I'm not familiar with the phenibut medication. What is the chemical molecule? Because that's probably sounds like a generic, non-generic, proprietary name.
Добре, зараз нам допоможуть. Напишіть діючу речовину, будь ласка, цього препарату, і ми повернемось до цього запитання. А зараз наступне від пані Анастасії. Чи буде дієвою психотерапія без медикаментозного лікування? Клієнт відмовляється від препаратів, які призначив лікар.
Yes, it will be if they will follow the psychotherapy and do that. As I showed in my slides, pharmacotherapy without effective psychotherapy or psychotherapy with placebo equally effective. So if they will, I mean, not for every person, we know that, but if person doesn't want to take medication and want to do therapy only, we see that in United States quite often, simply because there is more psychotherapy available and so on. And it's if they stick to the treatment and do the PE or WET, it's a very effective. So yes, I would happily tell them, yes, let's work with psychotherapy. I personally don't do that because I don't have enough time, but there are people in my group that will treat them. So I strongly recommend very close collaboration here between psychologists and psychiatrists, or psychotherapists and psychiatrists, psychotherapists, psychopharmacologists, what kind of a team approach. And then I would suggest definitely to do either CPT if they're um, interested in the cognitive concepts, if that bothers them and so on, or PE if it's people who want to do strong behavioral work, and either of those will be very effective. I don't think that any other psychotherapists that don't have exposure or cognitive approaches have been demonstrated strong efficacy. So I would say yes, definitely psychotherapy can be effective as long as one of those psychotherapies that have been studied. And that's what Dr. Mueller's lecture was all about.
Дякуємо, пане професоре. Ви відповіли, ця відповідь є відповіддю і на наступне запитання від пані Олесі, тому тут ми з вами вже розібралися. І останнє на сьогодні запитання від пані Крістіни. З вашого досвіду, з вашої думки, плюси та мінуси роботи з пацієнтами, які мають ПТСР, у стаціонарних спеціалізованих лікарнях. На чому важливо поставити акцент?
I think there's some, so in the United States, we moved a long time ago from the inpatient hospitalization to outpatient. The move was specifically driven by economy, not by necessarily treatment efficacy. We don't, in the United States, we almost never hospitalize people if we don't have to, if we can provide them treatment outpatient. So an outpatient work is efficacious. On the other hand, inpatient can be efficacious if because it can be done in more concentrated way, in a shorter amount of time, and people are doing that. I believe that working on inpatient allows you, for example, to do some of the prolonged exposure, maybe instead of once a week, to do it twice a week, and try to do it, or even 3 times a week, and try to do it in 4 weeks rather than in 12 weeks. I'm just giving you an example. How would I utilize the inpatient care? Pharmacotherapy, I would titrate people potentially faster because the inpatient, you can see them every day. You can see, do they develop side effects? Do you have something? You can do that. In inpatient, you can try to do things that otherwise impossible, like TMS. And there is a lot of new protocols for TMS that may be more frequent. TMS will be more effective for PTSD treatment. So there's some pluses in inpatient unit. The plus is that you see them every day. That's a big plus. You can move faster. The minus of that is inpatient unit creates kind of a closed environment. So the question, how much of that will stay after they leave the hospital? So it's very important to think about transition, or how to support them through the transition, that whatever they gain in the hospital will not be lost when they get out. The hospital creates safe environment. When they go outside, there is no so much support. So we work a lot on intensive outpatient programs, for example, without staying in hospital, but coming every day for 3 weeks to make sure that there is a good transition and the people get used to their home environment or whatever. So to me, the inpatient is opportunity to try to do more, how would I say, concentrated treatment, but also because of that, it's a requirement to make sure how we transition out. Thank you.
Дякуємо, пане професору. Дякуємо, доктор Таня Нікельсон, лекція якої буде наступного разу на нашому вебінарі, тож вже собі нотуйте, що ми продовжимо тему посттравматичного стресового розладу. Нагадаю, з нами було майже 600 учасників протягом цієї години 30 хвилин. Дякуємо вам за ваші запитання, дякуємо вам за цей вечір, який ви присвятили професійному розвитку. І нам повезло, що ми відпрацювали без повітряних тривог. Вам, пане професору, гарного дня робочого, бо він у вас якраз в самому розпалі. Дякуємо за цю лекцію і до зустрічі. Бережіть себе.